Hello, I am Jun Park. I'm an epileptologist at Rainbow, Babies and Children's. First, I would like to thank Monica Jones for inviting me here. And I'm very honored to be speaking about this topic and to be able to talk to you about, well, hopefully I can answer the question that was given to me. Now, I just want, it's blank here. I would like to make sure that we are all on the same page. Of course, here we are here to talk about focal epilepsy and drug-resistant focal epilepsy. And so, first you'd have a drug resistance after a child fails 2 or more medicines optimally dosed. And then after much discussion, the child is deemed a surgical candidate. And then the child goes through epileptic surgery, and at some point it is decided to whether withdraw medicine or not, or whether continue the medicine for at least a few more years. And then at the end, after discontinuing the medicine or medicines, you may be disappointed that the seizures come back. And so the medicine or medicines are restarted at some point. And so the question that I would like to answer, or the question that was given to me, was, will my child respond to anti-epileptic drugs after epilepsy surgery? This is a not so straightforward question. And so before I can answer this question, I would like to address 2 more questions. One, why do seizures return after epilepsy surgery? Once we understand this, then perhaps you might have tools to be able to understand why seizures may not respond to anti-epileptic drugs after surgery. In the process, I would like to not skip over this important question of when can AEDs be stopped? First, I would like to make sure that we are talking the same language. Dr. Gonzalez talked about disconnection. These are 3 common procedures that a child may get for epilepsy surgery. More commonly, a child may get a resection, that is removal of a brain tissue. That's pathologic. Disconnection, of course, which is a separation of the brain tissue from the rest of the brain. And sometimes laser or radiofrequency ablation, which is the application of intense heat to a tissue. This is often used when an area of focus is not easily accessible, as we see sometimes in patients with hypothalamic hamartoma. The first question, why do seizures return after epilepsy surgery? These are the points that I will discuss. I'm going to introduce you to the term epileptogenic zone. And when the epileptogenic zone remains, seizures may return after surgery. Second, incomplete resection that Dr. Gonzalez talked about. And third, probably less common and perhaps rare, is what we call secondary epileptogenesis. Now, the epileptogenic zone, this is a common term that we use amongst ourselves. And it's the minimum amount of cortex that must be resected to produce seizure freedom. This is a theoretical concept that cannot be objectively defined or measured directly. You know that the epileptogenic zone was removed when the child is seizure-free, off of medicine for years. So then you know the surgery was a success and the area of focus was completely removed. I don't want to complicate these things, but I want to introduce you to the concept of when an epileptogenic zone is still there. Okay. Imagine this is, say, left side of the brain looking from, say, this view, okay? And this is a view from underneath. And so that this is a temporal lobe on the left side. This is a temporal lobe looking up. Okay. Imagine that there is a lesion here. I call it the epileptogenic lesion, MRI positive. We can see that on an MRI. Now, when a child goes in to get a pre-surgical evaluation, the child gets the electrodes placed on top of the scalp. Now, the electrodes are somewhat far away from the actual brain, but with amplification, we pick up brain waves. Now, there will be multiple electrodes on top, as you know, but there will be no scalp electrodes underneath a brain. And so, scalp electrodes, when we see seizures, pick up seizure spread, meaning that if the seizure started from this area where the lesion is, when we see the seizure on scalp electrodes, we may see the seizure here, where the electrodes are placed on top of the left temporal lobe, over the left temporal lobe. We may see spikes or sharp waves. We often talk about spikes or sharp waves, which are indications of cortical irritation. And that may be in the vicinity of where we pick up the seizures also. So imagine that on scalp electrodes, we pick up seizures over here, we call ictal onset zone, and we see spikes or sharp waves in that vicinity, overlapping the ictal onset zone. But as I mentioned, the EEG, electroencephalograph, picks up seizure spread, and since there are no scalp electrodes underneath the brain, we don't see the seizure starting from here. But as we all say, lesion is king. And when we identify an epileptogenic lesion, and we suspect that the lesion where the seizure started from spreads to where the scalp electrodes are placed, and we pick up the seizure there, we assume with high confidence and from experience that is most likely the epileptogenic lesion, whether this lesion is a small tumor or whatnot. Okay. Now, when we don't recognize that the lesion is there, a part of the brain that we think the seizure started from may be removed, but it may slightly overlap with that epileptogenic lesion. So this means that most of the lesion is there, and perhaps the seizure may be coming around the lesion, and most of the epileptogenic zone remains, not resected. And so a possible scenario is that same seizures return 1 week after surgery with no change to AEDs. No one stops AEDs a week after, at least I don't. But the seizure returns to our disappointment. This is a possibility. Now, second possibility is incomplete resection, meaning that there was a resection done. Most of the lesion came out, some remains, and perhaps the seizure starts from around here. And so perhaps there's still an area where the seizure can be generated. So that means that another scenario is that after resection, you may not have any seizures for 6 months without any changes to medicines. But then, when AEDs are discontinued after 6 months, some seizures may return the same type, but less frequent and shorter and mild. This is a possible case where a medicine or two medicines may completely control a seizure, whereas before they didn't. Okay. Another scenario. The epileptogenic lesion is completely removed. We know on the MRI, we could see the lesion, and when we do a post-operative MRI, the lesion is gone. But then, I want to introduce you to this term, secondary epileptogenesis, a cortical area that has become epileptogenic because of influence of the primary epileptogenic area. This has been recognized for many, many decades. Now, sometimes this is hard to prove, but it is a remote possibility. When we pick up the seizures over the left temporal area, and I had called this ictal onset zone because that's where we see it on scalp electrodes. And let's say that the child had seizure for 10 years. And over 10 years, over hundreds of seizures, this area may in fact have become kindled, so to speak. And so even in the absence of the primary focus, now after some years, this area independently can produce seizures. And so even if the surgery was successful in removing the primary epileptogenic focus, now you may have a secondary area that has been kindled over years. And that may be a possibility why a child may have seizures after surgery. And so the scenario, possible third scenario, is that seizure returns 2 years after surgery, 1 year from the last anti-epileptic drug dose. Yeah. When this happens, perhaps one might treat this as, well, this is, say, a new seizure type, and let's see if an AED, an anti-epileptic drug, might control the seizures. It may not be so drug resistant. Okay. Second question. When can AEDs be withdrawn after surgery? This is an important question. Simple answer is the decision should be individualized. And I will tell you why this should be the answer. I will talk briefly about what evidence there is in literature, what is the preference of the epileptologists, what is the preference of the parents, and at the end, does it really matter when this medicine is stopped, whether it's stopped 6 months after surgery, a year after surgery, or 2 years after surgery? Does it matter? Now, this is a study we call Cochrane Systemic Review. It's a review of, so an author would review many studies and selects the most trustworthy, most objective studies, and those happen to be randomized controlled trials. And this author selected 7 eligible trials that included 924 randomized pediatric patients. Now, after reviewing these randomized controlled trials, looking at the question of this, early versus late AED withdrawal for people with epilepsy in remission. Now, during the selection process, the author defined early anti-epileptic drug discontinuation time as a period of remission of seizures of less than 2 years versus late AED discontinuation time, a period of remission of seizures of more than 2 years. What was the conclusion? Conclusion was that there is evidence to support waiting for at least 2 seizure-free years before discontinuing AEDs in children. Now, this, I will tell you how to think about this. You have to ask the question, did all the children, 924, did they all have the same surgery? That matters. Did they all have the same pathology? That matters. Did they all have the surgery at the same center by the same surgeon? with high skills. That matters. Now, so at the end, it depends whether this, in fact, is true. Second paper. Now, this author and the associates looked at, is there cognitive benefit of early post-operative AED drug withdrawal? The question is, can we take away the medicine 6 months, within 6 months of surgery? At the end, this study failed. The reason is that the collaborators or the researchers did not want to wait 12 months to withdraw medicines, because the study said, okay, you guys wait 6 months, you guys wait 12 months, you guys wait 2 years, and then let's see what happens. Well, the collaborators did not want to wait 12 months. On the other hand, almost all parents preferred early drug withdrawal. And so this study, there was no result. It failed. Okay. Now, the last point is, does it really matter whether a medication is withdrawn within 6 months of surgery or a year after surgery? And this study looked at timing of AED withdrawal and long-term seizure outcome after pediatric epilepsy surgery. This was a retrospective observational study of 15 European centers that included 766 children. Now, same questions. Did all the children have same pathology? Obviously, these were many different centers, and so the result is sometimes you take it with a grain of salt. Early AED withdrawal does not affect long-term seizure outcome or cure. It might unmask incomplete surgical success sooner. I think that sort of makes sense. Now we're down to the last question, which was the main question for this talk. Will my child respond to AEDs if seizures return after surgery? Now I've shown you 3 possible scenarios. And the first point, if the epileptogenic zone was not removed, as in the first case, probably the child will continue to be drug resistant because you have the same type of seizures. The epileptogenic zone where the seizures were generated remains. Second scenario, if the epileptogenic zone was partially removed, as in this case, seizures may be controlled with AEDs because now the seizures are less frequent, less intense, and very mild. And perhaps one anti-epileptic drug might control the seizures. And the third scenario, if the epileptogenic zone was removed in the third scenario, third case, but there is an area of secondary epileptogenesis, let's say, then it's sort of like starting from beginning. You have a child with a new seizure type, and perhaps first AED might control the seizures, or maybe not. So at the end, instead of me giving you statistical percentages of different studies, and the percentages may not apply to your child, I wanted to give you the actual tools to be able to critically evaluate whether that study looked at the homogeneous group, or whether there were all same children with same pathology, or whether the same surgeon did the surgery. At the end, those things matter, and the question of whether the seizure medicines will control seizures after epileptic surgery is dependent on many things. Thank you. Is there any question that I can answer? Yes, please.
In terms of early withdrawal of medication, I think there's another study from the Portuguese, the drug was
The question was, the question is early withdrawal of anti-epileptic drug. Is it beneficial to children? Well, as I mentioned here, that when you withdraw medicine, say within 6 months after surgery, the benefit is that you will know if the seizure will return or not. And the benefit is you wouldn't have to wait so long to find out if your child is seizure-free. And at the end, if in fact the child is seizure-free and the epileptogenic zone was removed, the child may benefit from discontinuation of multiple medicines that have side effects or that may interfere with cognition or learning or mood. And so it would help to discontinue some of the medicines to see if your child would become more alert, more active, happier, things like that. But another second benefit would be you would know earlier whether the seizures come back or not.
Is there any benefits of keeping the kids on meds after surgery?
Well, let me give you one scenario. Now, from my experience, children who've had stroke in utero and have hemiparesis, weak one side, and we know that very clearly the seizures are coming from that side where the stroke happened. And the seizures are very focal. Now, those patients typically go through hemisphere disconnection or hemispherotomy. And once it's done, most of the time, you know that the seizure focus was removed. And so I don't wait too long to discontinue medicine. In fact, one 9-year-old, 3 months after, decided not to take the medicines anymore. And so she's seizure-free for 5 years now. And so I don't know that I would have waited, probably I would have waited a little longer than 3 months, but she decided that she didn't want to take it, and now she's off the medicine, and mother says that her moods are different. She's happier, she's more alert, and things like that, you know. And so I don't think it would hurt to know sooner than later whether the seizure focus was removed and whether the seizures will return or not. Please.
So my son had functional hysterectomy in '92, and he was not given any anti-seizure medication after the surgery, which was kind of unique. He was fine for 2000. Oh. He was fine till 2000, where he had to go back in. So he had no seizures for 8 years. More than 8 years. So do you feel that there are connections that are neurological connections that are remade?
Well, if there was a functional hemispherectomy, that to me means that the hemisphere that was responsible for all the seizures have been removed.
Okay, so from '92 to 2000 he was fine, and then he started to up again.
Right. And so what was the reason for?
Cortical dysplasia.
I see. The question is, was the cortical dysplasia limited to one hemisphere? Right? And that's a valid question. Another question might be, if the functional hemispherectomy was done, was there an adjacent area near that, so on the other side, near where the cortical dysplasia was there, and that was not active in the beginning, you know? And then probably another possibility is, well, could we even think about secondary epileptogenesis? Now, there are many possibilities. There was a case that was earlier, after 2 hemispherectomies, still having seizures, you know? And so it'd be difficult to say what was the cause for.
I was just wondering if there was more connections that could be made, because it was, he was fine for so long. And he had another resection.
Yeah, I don't think that after a complete functional hemispherectomy, a connection can be made to the other hemisphere. Dr. Gonzalez can comment on that, but I don't think that's possible.
Well, no, it was still on the same side, so it was just funny that, and it just pops up. And now it's acting out. Okay, got my question answered.
Any other
Should
questions?
be up there.
Just
Yes,
a quick
at
announcement
the
before
end.
we go on with questions. Clearly, we're going to go over. So the 11 o'clock sessions are being moved to 11:20. And then we're also going to ask our panelists if you'll stay for lunch. That would be wonderful, because towards the end, we can also have some questions at that time. It's up to you if you'd like to stay. Maybe 2 more questions, and then we'll move on to Drs. Taylor and Ibrahim.
Hi, I have a question about post-hemispherectomy seizure recurrence. If you see a seizure presenting with, for example, like eye deviation to the left, can you assume that it must indeed be originating in the right hemisphere, or is there a possibility that now the left hemisphere has taken over that motor position to do the seizure on that hemisphere?
I'm not sure if I understand your question. So now, if you have a hemispherectomy,
Right.
And that hemispherectomy was part of the epileptogenic zone, and at the end, if the seizures return, would you have the same seizure semiology or characteristic? Is that what?
I guess just a general question, if a patient presents with a seizure where the eyes, for example, deviate to the left,
Yes.
would you conclude as a matter of fact that it would indeed be originating from a right hemisphere, or could post-hemispherectomy a seizure which presents with the eyes deviated to the
Oh, I see.
left, could it ever be actually coming from the left hemisphere?
Yeah. So the question is eye deviation a reliable sign to mean that the seizure came from the other side? Well, we call it aversive seizure, eye version, eye going to the left or right. Typically, we say that the eyes go to the left. So we say that the frontal lobe on the other side, with frontal eye field, is maybe responsible for that eye deviation to the left. Now, there are other reasons why eyes may deviate to the left, and it may not be a focal seizure. In patients with generalized epilepsy, meaning that the seizures didn't come from the other hemisphere, a patient with generalized epilepsy may have a focal symptom of eye deviation to either left or right. And so the question is the eye deviation a reliable sign for this particular case? And can we go by that? It may not be, because you may see that in generalized epilepsy. And sometimes eye may deviate late. And so that may not have as much information as, say, early eye deviation before generalized tonic-clonic seizure or something like that. So it's not so simple,
Thank you. I am the mom of a girl with cortical dysplasia who's had seizures return twice. And after the first surgery, I was in the camp of I want to stop the meds because I want to find out if it worked. And I was very black and white, either it worked or it didn't, and we need to find out sooner rather than later. I didn't really appreciate it worked mostly, and now the drugs may be good enough. Camp. That didn't really get explained to me. And I want to ask your questions about the phenomenon of the brain learning to seize. Certainly something I've observed is as the seizures return, they're mild to start, and then they build in intensity and frequency. It's almost like it's a learned mechanism. And is there maybe a benefit to not go down that path somehow with early stopping? I don't know what the right answer is, but do you think that's just a story, or is there some
No,
truth to
I
that?
believe that once a child has repetitive seizures for many years, the seizure may not be difficult to control years after. And in fact, if there is a child who may have been, say, a surgical candidate after 15 years or so, or 20 years, may not be a surgical candidate at that point. Depends on whether areas around that initial focus have become now also epileptogenic over years of kindling. So we want to try to control a seizure sooner than later. And I think this may explain why after so many years of seizure freedom on a medicine, you think about weaning the medicine off to see if the seizures will come back. Because medicine itself did not cure the seizure. It just prevented the seizures. And over years, perhaps the brain maturation and changes in the body somehow made the seizure threshold higher. And so now seizures don't occur so easily. And there may still be some seizure tendency, but the tendency may be low that you don't have to take, tendency may be low that you don't have to take medicine.
Dr. Lashwani, did you want to respond to that while Dr. Ibrahim and Dr. Abel set up their talk?
Absolutely. I think to tag along with what you just heard, I agree. We always worry about the seizures somehow being a learned bad habit. And that is why I think all of us in pediatric epilepsy, we really don't want the seizures to linger on any longer than is absolutely necessary to prove that the medicines are not working. And let's try to see if surgery offers a chance for cure. Now, we cannot do these experiments in humans for obvious reasons, but there is enough animal data to suggest that kindling is a real phenomena. It's kind of like having a bad influence amongst your friends, The rest of the friends tend to pick up those bad habits. So the same way, if there is a nest of neurons that is making electrical storms, we worry that the nearby neurons start learning the same bad habit. Now, whether it is in the vicinity of the same initial set, or is it cross over to the other side of the brain, these are both valid concerns. And we see some of our failures come out because of that reason. So I don't know if that was the main theme that we wanted to answer, or anything else. Is that it? Yeah, we do worry about kindling. We definitely worry about kindling. And coming back to the other question, can the same side of the brain cause the movement which we traditionally think belongs to the opposite hemisphere? Yes. I think nature made a redundancy in the way that the neural network is laid out. What do I mean by that? So imagine the left side of the brain is controlling the right side of the body. So about, roughly speaking, this is very simplistic, so that is the caveat, but roughly 80% of the fibers from the left side cross over to innervate the organs of the right side, the muscles of the right side. But there's about 10 to 15% of the fibers from the same side that go down to innervate the same side of the body. So there is a redundancy by nature. And when there is a damage, or if there is a malformation, or if the brain is just laid out differently, all bets are off. I think we still struggle to understand how much of the brain control is really distributed to the opposite side like we traditionally think, or has either adapted or changed because of the fact that there was a very early insult that may have promoted the same side of the brain to contribute more towards the function of the same side of the body because the opposite side was just not available. And these questions are very difficult to answer. I think we are getting better by tracking the fiber tracks, seeing how functional they are, but every case is so unique, every child is so unique that it's hard to make a general statement. But yes, sometimes we have a big malformed hemisphere. We do the anatomic hemispherectomy, means Dr. Gonzalez-Martinez does it, and the baby is moving all four limbs as if it doesn't miss anything. So how does that happen? So I think there's enough questions, and we don't have answers to all of those questions, but it is plausible that the same side of the brain controls the same side of the body. Dr. Gonzalez Martinez, would you like to add?
No, I completely agree. I think we need to really pay attention to what Dr. Lashwani mentioned about the plasticity. You know, when you have early insult, you have a completely change in the way the brain is organized. So you can see eventually changes in semiological signs, exactly like somebody asked if the contralateral side or eye version can come from the ipsilateral hemisphere. It can, because the brain is completely so reorganized.